So students, today we are going to examine our sensory system. So what is sensory system? Sensory system is that part of nervous system which carries information from different receptors and send it to our brain. What type of receptors? Receptors or what type of information? Information about the status of internal and external environment of our body. So what's the principle of this examination? Here, the receptors of the particular cells to be tested is stimulated by appropriate means and the findings are recorded. Okay. So, what's the importance of this testing? Here, by the examination of sensory system, we can grossly localize the disease process with the reflexes of the sensory system. We can grossly say that whether the pathology affects the spinal cord or nerve root or the sensory nerve proper, thalamus or cortex. Okay. So, grossly we can localize the disease process or pathology. That is the importance of this examination. So, in our sensory system, there are multiple modalities that we already know. We can grossly categorize them into mainly three groups. First one, exteroceptive sensations, then proprioceptive sensations, then comes combined and cortical sensations. There is another fourth group known as interoceptive sensation. Many receptors like osmoreceptor comes under that group, but we generally don't do it in our routine clinical practice. So I am excluding this and we will now focus upon these three types of modalities, that is exteroceptive sensation, proprioceptive sensation and combined and cortical sensation. So what are the exteroceptive sensation? As the name implies, the source here present outside the body. So there are three types of sensation in this group: pain, touch and temperature. And in the touch there is fine touch and foot touch. Under proprioceptive sensation, here the stimulus comes from body itself. Here is position sense, sense of passive movement, vibration sense, and muscle sensitivity. Then comes combined and cortical sensation. Mainly parietal cortex and responsible, parietal cortex as well as spinal cord, these are responsible for this type of sensation. There comes stereognosis, 2-point discrimination, graphesthesia, and tactile localization. So, when we are going to examine our sensory system, we are practically going to examine these modalities: pain, touch, temperature, position sense, sense of passive movement, vibration sense, muscle sensitivity, and stereognosis, 2-point discrimination, graphesthesia, and tactile localization. All type of proprioceptive sensation and combined and cortical sensation, these two type of fibers carried via the posterior column or DCP, that means dorsal column pathway. Whereas, as we know already, the fibers of pain and temperature, they are carried via ALS or anterolateral system. Pain and temperature fibers carried via lateral spinothalamic tract whereas fruit touch fiber or fibers for fruit touch that ascends through brain via anterior spinothalamic tract, whereas fine touch again these fibers carried via DCP or dorsal column pathway. So we already know about the main two sensory pathways. One is ALS or anterolateral system, and anterior spinothalamic tract and lateral spinothalamic tract come under that group. And there is DCP or dorsal column pathway. You already know about these two pathways. Just a quick recapitulation. So dorsal column pathway, as its name suggests, the fibers ascend through posterior column of the spinal cord, and anterolateral system, here the fibers ascend via either anterior or lateral quadrant of the spinal cord. And these two types of pathways consist of first order neuron, second order neuron and third order neuron. So if I draw a very easy diagram, say this is midline, this is the spinal cord, here lies brainstem, thalamus, corticosensory cortex. So in case of DCP, the first order neuron carries information from receptor, enters in the spinal cord via posterior root or through posterior root, ascends via dorsal column or posterior column and terminate in the brainstem. So here the first order neuron terminates. Second order neuron starts from here, crosses midline and ultimately terminate into the thalamus. Third order neuron started from thalamus and distributed all over part of the sensory cortex. This is DCP. This is brainstem, more specifically said medulla. This is thalamus and this is cortex. So this is DCP. What about ALS? Here the first order neuron carries information from the receptor and it terminates in the posterior root of the spinal cord. Second order neuron starts from there, crosses midline and ascends through either anterior or lateral quadrant of the spinal cord. It terminates in the thalamus, second order neuron. Third order neuron starts from thalamus and terminates at different layer of sensory cortex. So this is very gross information actually. Many fibers or many branches terminate in the reticular activating system, and I am just, for recapitulation purpose, I am just telling you the gross facts. Okay. So before coming to the examination proper, we have to know another thing, that is dermatome. So what is dermatome? We know that our spinal cord consists of multiple segments, and from each segment a pair of sensory nerve and a pair of motor nerve root arise. The sensory nerve innervate a particular part of our body surface. That particular part is known as dermatome. So the dermatomal distribution by sensory nerve is known as sensory map. Okay. So if we are asked to examine sensory system, we cannot test all the modalities in random area of our body. We have to choose a dermatome and do it bilaterally and dermatome-wise. If all the modalities are normal in a particular dermatome, so we can say that the corresponding spinal segment is intact. So that is the importance to know about dermatomes. Now you can see the picture. It's the dermatomal distribution from front and it's the dermatomal distribution from back. Okay. In our body we also can see that. Just put your hand like this over your occiput. The skin under occiput, that is supplied by C2. Okay. Now just put your palm like this, crossing the neck. This part is supplied by C3. Put this over your shoulder tip. This part is supplied by C4. Okay. Then just draw a midline through your arm which will end just below the forearm. This part is supplied by C5. Then comes C6. Part of the lateral part of the forearm and index finger and thumb. This part is supplied by C6. Then come the longest finger, that is the middle finger. Middle finger and adjoining skill. This part is supplied by C7. Now ring finger, little finger, adjoining part of our palm and medial part, that is supplied by C8. Rest of the part of the forearm and medial part of the arm, that is supplied by T1. Okay? And then comes T2. The upper medial part of the arm is supplied by T2. T2 extends in our chest. So, if we consider about this picture, as we descend downward, gradually the skills are supplied by T2, T3, T4, T5 up to T12. Okay. Now just put your palm like this, like hands in your pocket. This part, this lateral to medial or loin to groin part is supplied by L1. Now the upper part of the thigh, lateral to medial, it's supplied by L2. Now coming to knee joint and adjoining part, that is supplied by L3. Again, draw a line. The medial part, dorsum of the toe, along with red toe, that part is supplied by L4. These two digits and adjoining part, that is supplied by L5. L5 actually proceeds diagonally from outer aspect to inner aspect of dorsum of the foot, and that part is supplied by L5. Last two toe, that means little toe, back part of the sole of the foot and ankle, that part is supplied by S1. And back of most of the part of the back leg, that is supplied by S2. Now you have to know about all the dermatomes, but obviously in your exam some dermatomes are examiner's favorite, so just remember that. You are frequently asked about C4. C4 supplied shoulder tip, okay. Then middle finger, it's supplied by C7. Just remember that C7 has the longest spinous process, and this finger is also longest, okay, just for remember. Okay, that is C7. What about little toe? Little finger. Little finger is supplied by T1. And knee joint and adjoining area, L3. Little toe, that is supplied by S1. So, if you are asked about C1, because we are starting here as from C2. If you are asked about C1, C1 gives no supply to skin. What about axillary supply? Axilla is supplied by T3, not T2. Though T2 supplies the upper medial part along with thorax, but axilla is supplied by T3. And we cannot examine some dermatome due to exposure problem, just for your information. What about S3, S4, S5 and coccygeal nerve? They supply the skin which is present in a concentric ring around the anus. That part is supplied by S3, S4, S5 and coccygeal nerve. Okay. So C2, C3, C4, C5, C6, C7, C8, T1, T2, T3, T4, T5, T6, T7, T8, T9, T10, T11, T12. Okay. L1, L2, L3, L4, L5, S1, S1, S2. Okay. Now we are frequently asked about T8, T10 and T12. T8 corresponds with the rib margin or lower rib margin, whereas T10 umbilicus, okay, and T12 pubis. So T8 rib margin, T10 umbilicus and T12 pubis. So that is the dermatomal distribution from front and from back. Now coming to examination problem. First, we will discuss about exteroceptive sensation. We start with pain. So, exteroceptive sensation means your sources are present outside our body. So, for eliciting pain, what's the most common stimulating object? What's the most common stimulating object? use a pin with rounded head and long shaft. The shaft should be long enough so that you can introduce your thumb and index finger between the rounded head and your patient's body surface. It's ideal that if only the sharp part protrudes from your thumb and index finger. In that case, your thumb and index finger act as guard and you can deliver a very uniform and slightest pressure or slightest pain without damaging tissue. Okay, if the shaft length is very much small, then you have to apply pressure just by manipulating the head part. In that case, the pressure will be inadequate, ununiform, and that may cause damage to patient's tissue. So, just keep it in your mind. Take a pin with long shaft and rounded neck. Then what is the preliminary step? In our routine clinical practice, we should start the sensory system with for a particular dermatome which is expected to be normal from history already elevated. But in our pre-clinics, that means in our physiology exam, we should ask our examination to mention a dermatome for us because there's two advantages in it. Because otherwise you have to test all the modalities in all the dermatome, which is a very time-consuming and tiring job for you, as you can understand. And if you ask your examiner to choose a dermatome for you, then he or she will know that you have idea about dermatome. So just ask you to tell a dermatome where you can going to elicit all the modalities. Now, what should be your instruction to your patient? First and foremost, he has to close his eyes throughout the procedure and just tell him that now during the examination proper is going to feel a painful stimuli, and whenever he feels something, just inform you either by raising his hand or by telling yes. Okay. Now choose a dermatome, do the test or apply pressure. When the eyes are closed, just apply pressure dermatome wise, and always do it bilaterally. Okay, like this, yes, this, yes. Okay. Now, what should be your question to your patient? What should be your question? Can you feel something? If yes, what kind of feeling it is? Okay. If you feel a pointed sensation, is it sharp or blunt? Is it bilaterally equal or not? Or not? So, can you feel something? If yes, what kind of feeling it is? Is it sharp or blunt? If you can state a point. And is it bilaterally equal or not? So, this part is general examination of pain, which we have to do for all the persons, either patient or any normal participant. But if the person is a patient indeed, then he or she may complain abnormal sensation in a particular dermatome. In that case, go for detailed examination of that particular dermatome after completing the general part of the examination. What is detailed examination? Just at first, say this is the abnormal point. Okay, point of abnormal sensation. So first mark it. First mark the position or point of abnormal sensation, and proceed your pin from abnormal site to normal site. Okay, proceed your pin from abnormal site to normal site. Like if this dermatome is damaged, just proceed it like this. So your pin is actually shifting the dermatome, and by that you can say that one dermatome is abnormal, another is normal. In the normal dermatome, the sensations are normal. Always proceed the pin from abnormal side to normal side, not normal to abnormal, always abnormal to normal, because the patient can feel the difference better that way. So always proceed for abnormal to normal side. So here what should be your question? Now you have to ask the patient, do you feel any difference? Do you feel any difference between two different points? If yes, what kind of differences? What type of difference is it? Don't ask any leading question like, is it sharp? Is it sharper than the previous stimulus? No, not any leading question. Just asking the general way, do you feel any difference between two different points? If yes, what type of difference? Okay. So this is the question of detailed examination. Now coming to touch sensation. So all the other steps, all the other preliminary step or instruction to the patient question of touch sensation examination is very much similar to that of the pain sensation. Only difference is the stimulating object. So what is stimulating object in case of touch? For fine touch, it's cotton piece. For true touch, it's blunt end of pin. So for true touch, the blunt end of pin. What is cotton waste? Just take a ball of cotton, roll its one side that way and make it a cotton waste. So this is cotton waste for fine touch, for excitation of fine touch, and the blunt end of the pin for excitation of true touch. Here also ask your examiner to choose a diameter for you. Instruct patient to close his eyes throughout the procedure and inform him whenever you feel something on his skin. And your question here also, can you feel something? Is it bilaterally equal or not? Like that. After completing the general sensation, if there is any abnormal sensation, go for detailed examination of that particular diameter. So that is touch. Again, always bilateral. Then come temperature. In our regular clinical practice, generally we don't do the examination of temperature sensation because it provides us no extra information than that of testing pain sensation. But in our preclinics, if we are provided with proper stimulating object, we have to do it. Now for sensation of the stimulating, what is the stimulating object for cold state sensation? The ideal stimulating object is test tube containing water of 30 degrees centigrade. If you are not provided with that, you may also use any metallic object like tuning fork. It's cold. And for heat sensation, test tube containing water of 44 degrees centigrade. Now all the other procedure, initial step, instruction, everything that is very much similar to that of this testing of pain. Now in case of cold sensation, we should use test tube containing water of 30 degrees centigrade and heat 44 degrees centigrade. Now too cold or too hot water we can't use because that can stimulate our pain fiber. So we have to use 30 degree and 44 degree centigrade temperature water, and we have to maintain that temperature throughout the procedure. Okay. So that is our examination of exteroceptive sensation, pain, touch and temperature. Okay. Just keep one thing in your mind. If we are going to examine the fingertips, our fingertips are a little bit insensitive to pain, but they are very much touch sensitive. Okay, just keep it in your mind. present inside the body. First come position change. Now instruct your patient to close his eyes and you will choose one limb of him, move it at different direction and put it in a particular position. Ask the patient or instruct the patient with closing his eyes, just put the another limb in the identical position. Okay. First you put one limb in a particular position and ask your patient to move another limb in identical position. If he has proper position sense, he can do it. Then come sense of passive movement. Generally we do the test in different digits like forefinger, thumb, great toe, but we can also do it in elbow, wrist, etc. Now here first you have to demonstrate your patient about different direction of movement like upward direction, downward direction, and instruct him to inform you about the new position which you are going to achieve after this movement like up, down, okay. So demonstrate him about the direction of movement, upward, downward, and demonstrate him the positions or the new position which the digit is going to achieve after that particular movement. Like upward movement, position is up, downward movement, position is down. Just instruct him that way. And obviously during examination his eyes will be closed. Okay, so during examination just ask him to close his eyes and what will be your question? Can you feel any movement? If yes, what's the position of digit now? Okay, so at first if you are considering about great toe, at first just fix it. Okay, fix the great toe and initiate your movement. Ask, his eyes will be closed. Ask the patient if or can you feel any movement? If yes, just move it upward or downward and fix it in down or up position. And ask the patient what's the position of your great toe. He will say up. Okay. Now your movement should be slow and precise. And another thing, always put your thumb and index finger the side way. Okay, not on the or under the great toe, because that way your patient can predict your movement. Because if you put your finger this way, you are going to initiate the downward movement. If it's under your toe, then you are going to initiate upward movement. So just keep your thumb and index finger in a neutral position. Okay, like this, not like this or this. Okay. Sense of vibration. So before doing the actual test, your patient has to be accustomed with the feeling of vibration. So first tell him to open his eyes, make it strike and vibrate. Just put it over your patient's clavicle or any bony prominence and ask him to feel the vibration. Okay, because also tell him that because during the test proper he has to close his eyes and you are going to put the base of the tuning fork or the vibrating tuning fork over different bony prominence of his body, and he has to feel the vibration and he has to notify you. Always tell him that it's the feeling of vibration which he has to record, not the humming sound that coming from his vibrating tuning fork. Not the humming sound, but the feeling of vibration that he has to notify his examiner. Okay, so first make him accustomed to the feeling of vibration. Now do it bilaterally in different bony position, bony point of the patient, like clavicle, lower end of the radius, olecranon process, medial malleolus, like this. Always do it bilaterally, like that. Okay, always do it bilaterally. And what will be your question? Ask the patient, can you feel any vibration? If yes, then is it bilaterally equal or not? So this is the first part of your examination. Now just tell your participant, now we are going to repeat the procedure, but this time he has to inform you when he can't feel any vibration. Okay, just to inform you when he can't feel any vibration. So again, you can strike, put it in lower end of the radius, and when he can't feel vibration, he will notify you either by raising his hand or by saying yes. Immediately transfer the base of the tipping fork in the opposite corresponding point of the opposite hip. The normal response is that the patient should feel vibration 3 to 5 seconds more in the contralateral side. The ideal or normal response is that the patient should feel vibration in the body point of the corresponding limb for 3 to 5 seconds more. But if he can't feel anything, that means the contralateral, if no response, that means contralateral side is abnormal. If he can feel vibration more than 5 seconds, that means the former side is abnormal. So this is the sense of vibration. And now come muscle sensitivity. Ask your patient to close that he has to close his eyes during the procedure, and he has to inform you whenever he feels any discomfort. Now what we are going to do? Just put your thumb firmly over a muscle bar, either in arm or forearm. Just put your thumb over a muscle bulk of patient firmly, and after applying a certain amount of pressure, he will feel discomfort and he will notify you. So that is the sense of that is muscle sensitivity. If the muscle sensitivity is very much high, that means if muscles are very much tender, even a lighter pressure can elicit pain. Okay, and if sensitivity is low, then you can exert all the possible force without any objection from the patient's side. Now in this test, you have to elicit deep pain also. Just squeeze your tendo achilles, just squeeze this patient's tendo achilles with thumb and index finger like this until pain is produced. Okay, so that is about muscle sensitivity. Then come combined and cortical sensation. Under this group, first is stereolysis. It's ability of a person to identify an object merely by feeling it, by its size and shape, without seeing it. Okay, so just ask your patient to close his eyes and put different objects over his palm. Do it bilaterally and ask the patient, what is this object? Okay, you have to do it bilaterally and just notice the accuracy or the time of recognition of the object and make a bilateral comparison. Okay, you have to put different object in his palm and ask him what's the object. Just see his accuracy and time of recognition. Now, the objects must be familiar to the patient, easily identifiable, and large enough for a weak hand to feel. Okay, so familiar to the patient, easily identifiable, and large enough for a weak hand to feel. Always make a bilateral comparison. So that is diagnosis. Then come 2-point discrimination. The ideal stimulating object for this is compass aesthesiometer. But we are not provided with that instrument. That is why now I am going to use this compass. We are familiar with this object because in your geometry box you have often seen it. Now if you are not provided with this object too, then what will you do? Then you may use to pick, but in that case you have to engage your two hands for manipulating or adjusting distance between these two, the distance between the 2 points. So you may just use 2 of your fingers like this. This is also acceptable. Okay. So the ideal instrument is compass aesthesiometer. If you are not provided with that, this instrument is also alright. Compass aesthesiometer is very much like this. Only it has an adjustable screw in the middle of the limb, so that the distance between these two limbs is adjusted. Okay. Now what is the sense of 2-point discrimination? The 2-point discrimination is the ability of a person to identify 2 points separately when these 2 points are stimulated simultaneously. Okay. So now just ask your patient to close his eyes. Make these 2 points far away like this. At first far away. Just choose a dermatome. Ask your patient to close his eyes and just put it like this. Ask your patient whether he is touched at 1 point or 2 points. Say he is saying it's 2 points. Then just approximate it. Approximate it until the patient makes any error. What type of error? A time will come when he will feel that he is touched at 1 point. Though the stimulating points are 2, but he can feel that, but he will feel that it's coming from a single point. So approximate it until the patient makes any mistake. Here you have to know about minimum separable distance. It's the minimum distance between these 2 points where a patient can feel the 2 points separately. When they are stimulated separately but simultaneously, the patient can feel it as 2 separate points. That is the minimum separable distance. That is the minimum distance between these 2 points where a patient can feel it separately. Distance below it or distance less than it, a patient will feel that the stimulus is coming from a single point. Again, do it bilaterally, and actually the touch receptors are present in variable concentration in a different part of our body. That is why in our palm the minimum separable distance is less than 5 mm, whereas in our back it's more than 5 cm. Both are normal. Then come graphesthesia. It's the ability of a person to identify letters or numbers which is written on your skin surface, on his skin surface. Okay, like his eyes are closed. Now just trace out a number in a particular dermatome and ask him what the number is. If he has proper sense of graphesthesia, he can tell you the original number without seeing it. Okay, do the bilateral comparison for accuracy or for time of recognition. You have often seen it in multiple films, I think. Okay, and then comes step-time localization, last one. Here also instruct the patient to close his eyes. Now you are going to stimulate multiple points in his body and ask him immediately localize or locate that point with his finger or a pen which is provided to him. At first the examiner will make a point, mark it and then immediately after that touching, the patient is going to localize that point. Okay, mark that point too. See, the examiner mark it like this. Okay, the patient's eyes are closed. Now he will localize that point like this. Okay, now just measure the difference, the distance between these 2 points. This is known as localization distance, which is where touch spot's concentration is more, this localization distance is less, like fingertip, palm. Where the touch spot's concentration is low, here the localization distance will be more, like back part. So that is tactile localization. So basically this is the examination of your sensory system. Now you can go through your any practical standard book, and during your exam you may be asked about some relevant clinical entities like what is anesthesia, what is analgesia, dissociative anesthesia, and what happens when there is lesion in brainstem, spinal cord, sensory loop, all about this. And just go through any standard book, and I think you have already know it from your theory classes. Now let me show you these modalities in a normal subject or normal participant. You should communicate with your patient in one language. I'm going to select the dermatome first. Say this is C6. We have to do it bilaterally. Take the pin. Just hold it like this way. Only the sharp end protrudes. Okay. So we have to do it in all the dermatomes bilaterally. Say if he complains about any abnormal sensation or he can't feel the painful stimuli proper in these dermatome, just proceed your pin like this and ask him, is it equal in every point or is there any difference at different points? Okay, but she is a normal participant, that's why her all the senses are supposed to be normal. So this is sensation of pain. Now come fine touch. Just take a cotton ball, roll it and make a whisk. Actually, ideally, she should stand in a normal anatomical position like this. Fine touch. Temperature. We are not provided with any testing containing water. So for sensation of cold, I am just using this metallic object. So this is testing of exteroceptive sensation. Now coming to proprioceptive sensation. First, muscle sensitivity. আমি তো রেগুলার বিভিন্ন দিকে ঘুরি একটা জায়গায় ফিক্স করবো, তুই ওই হাতটাকে ফিক্স করবি চোখ বন্ধ করে। That is position sense. That is position sense. Then we are coming to passive sense of passive movement. আচ্ছা, যখন কোনো মুভমেন্ট বুঝতে পারবে তখন হ্যাঁ বলবে, তারপর কোন দিকে হাতটা আছে সেটা বলবে। ফার্স্ট ডেমনস্ট্রেট করবে, এটা হচ্ছে ধর আপওয়ার্ড মুভমেন্ট, ডাউনওয়ার্ড মুভমেন্ট, চোখ খোলা প্রথমে দেখা যাবে। আপওয়ার্ড মুভমেন্ট, ডাউনওয়ার্ড মুভমেন্ট, এটা আপ পজিশন, এটা ডাউন পজিশন, ঠিক আছে? আচ্ছা, এটা চলবে। নাও আই এম গোয়িং টু এক্সামিনেশন প্রপার। ফিক্স দ্য ফিঙ্গার ফার্স্ট, ফিক্স দ্য ডিজিট ফার্স্ট, হোল্ড ইট লাইক দিস, not like this, not like this. This. কোনো মুভমেন্ট বুঝতে পারছিস? পাচ্ছিস? আচ্ছা, কোন দিকে আছে? আপ। That means he has proper sense of passive movement. চোখ খোলা। আচ্ছা, এবারে হচ্ছে now vibration sense. First, accustom your patient with the feeling of vibration. চোখ খোলা থাকবে। Just choose a bony prominence like this. Make it vibrate. আচ্ছা, এরকম এটা হচ্ছে ভাইব্রেশনের ফিলিং, শব্দটা না, জাস্ট ফিলিং। ঠিক আছে, এবারে তুই চোখ বন্ধ করবি, যখন এই ফিলিংটা বুঝতে পারবি আমাকে বলবি হ্যাঁ। আমি দুদিকে করবো, দুদিকে সমান শুনতে মানে বুঝতে পারছিস কিনা বলবি। পাচ্ছিস? দুদিকেই কর। আচ্ছা, এবারে আমি আবার জিনিসটা রিপিট করবো। এবারে তুই আমাকে তখন মডিফাই করবি যখন এখানে তুই আর কিছু বুঝতে পারবি। ঠিক আছে, ইমিডিয়েটলি শিফট ইট টু অপোজিট সাইড। ঠিক আছে, কিছু বুঝতে পারছিস এখানে? বুঝতে পেরেছিস? তাহলে ইট ইজ দ্য নর্মাল রেসপন্স। You should feel it for 3 to 5 seconds more. So when you can't feel vibration in epilepsy, just shift or immediately shift the base in the corresponding point of contralateral. She should feel it for 3 to 5 seconds more. আচ্ছা, এবারে তোর চোখ বন্ধ থাকবে, আমি একটা প্রেশার দেবো, যখন তুই কোনো ডিসকমফোর্ট ফিল করবি আমাকে বলবি। Just choose a dermatome like C5. Put your thumb like this, give firm pressure. Okay, so after applying a certain pressure, she will feel discomfort or pain. Do it bilaterally. Now you have to elicit deep pain. For that, just squeeze her tendinoacids with your thumb and index finger like this until the pain stops. Do it bilaterally. So this is the testing of proprioception. Now we have to go for combined and cortical sensation. First comes stereognosis. আচ্ছা, তোর চোখ বন্ধ থাকে, আমি তোর হাতে কোনো অবজেক্ট দেবো, তুই জাস্ট ফিল করে বলবি কী অবজেক্ট। ঠিক আছে, চলো।
Pen.
Like this. This is stereognosis. The object should be familiar to the patient. Now, 2-point discrimination. Just this is the first position, far away from each other, 2 points. Spot. একটা আছে না দুটো? দুটো. Approximate it. এখন দুটো. Now, okay. Do it bilaterally. So that is 2-point discrimination. Actually, proper exposure is also needed. Now, graphesthesia. In graphesthesia, I am going to tracing out different objects, different numbers and letters in a particular dermatome. This is a blank plate. First, her eyes will be closed, and I am going to touch one of his point on his surface, body surface, and immediately after she has to localize that point. ঠিক আছে, তুই চোখ বন্ধ করে থাকবি, আমি যে পয়েন্টটা ছবো সঙ্গে সঙ্গে তুই ওই পয়েন্টটা দেখাবি তোর আঙুলের টিপ দিয়ে। ঠিক আছে, so mark it, and this is the localization distance. So this point is marked by me and this point is marked by her. This is the point made by the examiner. This is the point made by the normal participant. So we should measure the distance. Okay. Again, we have to do it bilaterally. Okay. So this is the localization distance and that is tactile localization. Now, before closing my class, just I am going to show the dermatomes or grossly overall body. Show the manager and localization. So, the skin over occiput, that is supplied by C2, C3, C4. Now, C5, C6 up to index finger, C7 including the middle finger and adjoining part, these two fingers, C7, C8, T1, T2, T3, T4, T5, T6, T7, T8 up to T12. Then L1, upper part of his thigh, upper part of her thigh. L2, knee joint and adjoining area. L3, draw a line over tibia which extends in the dorsum of foot covering the great toe. That is L4. L5 goes diagonally from outer aspect of the tibia to inner part of the dorsum of foot involving to middle toe. That is supplied by L5. The little toe, adjoining toe and the corresponding